Hello everyone, welcome to lecture 30. We are continuing our conversation on chapter 7, radiation therapy and radiation safety. And today we're going to talk about radiation damage and the risks that you are at relative to that different types of damage that can possibly occur. So you should have done a reading from Kane 7.4 and the section from Hobby. Now, unlike previous units, lectures, we are not going to be starting off with multiple choice questions. I think I have one or two at the end, but of course we're at this point in the semester where I would not be allowed to give you any graded assessments during the class, so the online or the in-class quizzes would have stopped by this point of the class, so I was not giving any of those questions anyways. So you're going to have to come up with your own questions as you try to figure out if you understood the reading coming into it. But I still need you to do the reading first, because remember, the point of the reading was not about answering the questions. The point of the reading was so you can understand what we're talking about before I get to these lectures. So the words and phrases and ideas that I'm presenting, you will have seen them before, and this won't be the first time that you've seen it. So let's get into this idea of radiation damage and the risk. Okay? So turns out you're exposed to a lot of radiation in your life. So these are some graphs from the radiobiology book that I use in that course. And it's just showing you what are the various sources of radiation resulting from human activity. So there is natural radioactivity in the environment. That is true. And those come from things like radon and thoron. These are present in the environment. There's radiation from space. There's radiation from the stones underneath your feet. But first, let's just talk about, due to human activity, where are you getting radiation from? Buried radioactive waste continues to illuminate you. Luminous wristwatches have radioactive paint. Power plants put things in the air that you breathe. You get dental x-rays every other time you go to the dentist. When you go up into the air on international air travel, you're getting extra cosmic ray dose because you're above some of the protective layer of the atmosphere. There's still fallout coming from nuclear weapons testing. Televisions and computer monitors put out some amount of ionizing radiation, and of course medical x-rays. So the effective dose for all this is dominated by the medical radiation. So these other sources are all very minimal, maybe negligible. Some people argue even beneficial. That's not exactly clear yet if these little bits of radiation actually help the human species by causing some mutations that help us to improve ourselves more quickly. Unclear about that yet, but they're minimal. But from medical radiation is going to be the highest source of dose. So if you look at how this dose is broken up by a human, so the average total effective dose per person is about 6.2 millisieverts. So sieverts is this unit that we had talked about before, right? It's the equivalent dose unit. And you'll see that that dose is dominated by some medicine where interventional fluoroscopy accounts for 7%. Conventional radiology, that would be any kind of x-ray and other fluoroscopy, is 5%. Nuclear medicine, which we talked about, injecting you with radionuclides, 12%. And CT or computer tomography, 24%. So the highest fraction of medically prescribed radiation dose. So we're getting a lot of radiation all the time from our natural environment, and we're giving a lot more from medical interventional therapies, either diagnostic, imaging, or therapeutic. So the question is how do we characterize, quantify, or calculate how dangerous that is? I think this is one of the biggest sources of confusion amongst the general public that physicists can help to alleviate. We understand risk. Is it dangerous? Sure. How dangerous? That's a tough question to answer, but because we understand risk, we are in the position to answer that question and to help people who don't understand risk and are tend to wild overreaction, tend to wild speculation because their inability to calculate real risk tends to make them more vulnerable to incorrect assumptions. So being able to handle the risks due to these radiation exposures is an important part of being a medical physicist. So let's just start to introduce that subject. So if you get sick from radiation exposure, the type of illnesses you will manifest, or that a patient would manifest if you're treating a patient, can be grouped into one of two categories. They're either acute or they're chronic. And whether you get an acute or chronic illness depends kind of upon two things. The dose is important, sure. We've talked about that before, where like 1 gray is delivered in a fraction. We use that to kill cancers. 40 gray all at once will kill you, period. But dose rate is also really important. 40 gray will kill you if delivered all at once. But 40 gray delivered over 40 years of your life, not the same thing. Not the same thing at all. That will not kill you. It probably is not good for you, but the effects that it manifests are going to be very different. So this is what's tricky about radiation, because it's not just the dose. How quickly did you get it? So accidentally being exposed or exposed in a bomb blast, like at the Hiroshima and Nagasaki bombs, that was all at once. That's one kind of effect. On the other hand, people living in fallout zones where you're getting exposed to low levels of radiation maybe over 6 months as the atmosphere clears itself, very different effects. All right, so we need to understand those effects. But in general, you can get acute effects from high doses in a short amount of time. Nuclear accidents, bomb blasts, things like that. And these can lead to acute things, and they all kind of fall into one syndrome that we call ARS, the acute radiation sickness. So acute radiation sickness is a syndrome. Syndrome, it means it's just a kind of a collection of symptoms and pathologies that all occur together. None of them is a particular disease. So what falls into acute radiation sickness? Burns. You'll actually get reddening on the skin. Hair loss. All your hair falls out. Nausea. Gastrointestinal collapse because you lose all the epithelials in your GI tract and your stomach. CSN is central nervous system collapse, and then inevitably death. All right, so all of these things kind of come from burns on the low end. So of a high dose in a short time, the lower end of that could be just a burn. The other things could then accumulate. And the high end could be death, literally within 15 minutes, if you got a massive amount of radiation, and that has happened. And so all those are acute things. They tend to manifest themselves. It can be within minutes. Actually, in the radiobiology course, you will see that the GI collapse and nausea, this is one of the predominant indicators or dosimeters of how much radiation you got. If you're exposed in a nuclear accident, many times there's no way of knowing how much radiation did you get. But the number of minutes that elapse between exposure and nausea, which is vomiting, actually is a very good indicator of how much radiation you get. And this will manifest within 15 minutes. Usually, with a decent, a radiation dose to make you seriously sick or kill you, your stomach starts to feel it because those cells die effectively instantly, and onset of vomiting within 15 minutes. On the other hand, high doses or even low doses over a very long time cause chronic effects. So these acute things, they manifest quickly, they're very overt, you have no problem spotting them. Chronic effects are hidden, and they're less likely to be noticeable. So chronic illnesses or disorders, which I'm going to give some examples of, like cataracts will be one. They tend to accumulate over time. So any type of illness that takes 10 years, 20 years to manifest itself. And then, of course, the cancers or heritable disorders. So the heritable disorders, we actually, in the field of radiobiology, used to call genetic effects. It just means that something happens in your genome and you don't get sick, but you pass it on to your offspring. Birth defects, other illnesses in the child, stillbirths, things like that. We used to call them genetic effects, but then we realized that cancer is a genetic effect because it's due to damage to your genome. So now we call it heritable disorder because it's things that are inherited by your progeny. You pass them on to them. And these are all going to be chronic effects. They occur down the road. You're not going to notice them in 15 minutes or an hour. They may pop up over 10, 20 years, or you might never notice it until an effect is manifested in your offspring. So that's chronic, kind of long-term type effects, and acute, these kind of short-term, more immediately serious effects. But you can't say one is more serious than the other because cancer and heritable disorders are pretty serious compared to hair loss. All right, so I don't tend to use that word, but it's the way they manifest themselves. All right, I hope that makes some sense. So now we have to understand two words. There are two types of ways of determining how at risk you are for these types of effects. So high doses, we say, are deterministic. They're deterministic in terms of probability and severity. This is the definition of deterministic. So deterministic means that both probability, which I'm showing in blue, and severity, which I'm showing in red, show a threshold. Below this threshold, there's no effect at all, right? So blue, there's the probability of getting it. It goes down until it's some dose below which there's 0. All right. Same thing with the severity. So what is the probability? What I'm talking about? What is your probability of getting? Let's just say what's the probability of your hair falling out from an X-ray? All right. From a dental X-ray, it's 0. It's never going to happen. Now, as we increase the dose, dental X-ray still 0. Chest X-ray 0. CT scan 0. But as you keep increasing the dose, there is some dose at which finally, okay, now it's non-zero. If I give you an X-ray that's this much dose, there's some small probability that your hair will fall out. And as you increase that dose, the probability starts to go up. So that's a hallmark of a deterministic effect. It's got a threshold below which there is no risk, and the probability increases as you increase the dose, which is just what you expect. More dose, more dangerous; less dose, less dangerous; some dose, not dangerous at all. That's a deterministic effect. And also, the severity increases with dose. So how bad your effect is. So a good example of this is skin reddening or burns, which they call erythema. So this is just a skin reddening, and below a certain dose, you get no skin reddening at all. As you increase the dose, this sometimes happens to cancer patients who are being treated by radiation fields, that the skin will start to get red and will start to get burned. And the more dose you get, the redder it can get, the more burned you do get. All right, that's a deterministic effect. It's going to show up kind of right away. The more dose you get, the more burning to the skin you're going to get. Below some dose, it's not going to happen at all. All right, so some examples of this are these cataracts. It's weird because the cataract is a clouding of the lens of your eye. And you would think that that wouldn't be caused by radiation. It turns out that the formation of cataracts is very, very related. The probability of getting it is almost directly related to the dose in almost a linear fashion. It's really, really predictable that as the amount of dose you get goes up, the probability of getting cataracts goes up as well. So this is bad for people who are being treated for brain cancers, where we try to treat their brain cancers with external beam therapy, X-ray beams through the skull. If their eyes are getting irradiated, then the probability of getting cataracts on your lens goes up. But it's predictable. It's deterministic. You can determine with some certainty what the probability is. You could calculate or determine what the severity, how bad it's going to be, is. All right. So most of these kind of acute things are deterministic. Burns, hair loss, nausea, GI collapse. Those are deterministic effects. These are all mostly high doses. Now the other things were the low dose chronic effects. So high dose acute deterministic. The other category is low or long doses, chronic, and we say they are stochastic. So the two types of illnesses are like acute and chronic. Acute illnesses are usually deterministic, and the chronic illnesses are usually stochastic. So stochastic and deterministic are kind of opposites of each other. What does stochastic mean? Okay, stochastic risks, illnesses have a certain characteristic there. The first is, let's look at the probability. So the probability of a stochastic illness, and the examples of that are cancer and heritable disorders, so passing on birth defects, other mutations to your progeny. There is no threshold dose. As far as we know, any little dose increases your risk. Now, it might not be much, but there is no such thing as a safe dose at all. It is a non-zero risk. There's a non-zero probability as soon as you get some dose. and then that dose just increases. Now I'm showing it kind of linear here. It doesn't mean it has to be linear. I'm not saying I actually know what this curve looks like, but the point is there's no threshold, right? The threshold was here. Threshold is a dose below which there is zero chance of getting it. And then, of course, if there's zero chance of getting it, the severity is zero as well. All right, that has to be true. But for stochastic things, there is no threshold. Whatever that probability curve is, linear, straight, curvy, it dead ends right at zero. All right, so that's one characteristic of a stochastic illness or risk. And the other is the severity is just a flat line. Right? The severity is 100% if you get it. The severity is all or nothing. And of course that makes sense if you think about it for 1 second. There is no such thing as half cancer. Oh, I had a really mild case of cancer. It doesn't work that way. You either have cancer or you don't have cancer, right? You have either passed on a birth defect or you haven't, right? The severity is all or nothing if you get one of these effects. And so that's why we don't want to take on even limited amounts of probability. If the severity is scared with the probability, you might be willing to take this risk, right? But if you ask anybody, so if you say, are you willing to expose yourself to some risk for some amount of money? You say, well, what's the probability? Well, it's small. Well, what happens if I bet wrong and it happens? I'll break your pinky. Okay, you say, well, that's not so severe. I think for a large amount of money, I might do that. But anyone would say, even if the risk is small, but what's the consequence? Death? People are not going to take that gamble, right? So we can't handle even low amounts of probability of risk when the severity is all or nothing. So you have to think about these things because it's going to kind of inform how we handle radiation and the procedures that we use, the precautions that we take if you're a radiation safety officer, the kind of policies and rules you put in place to keep your people safe. If you're a medical physicist, how you handle radiation when you're treating patients. And really, the way that we implement that is we have a belief. So I always talk about this. There is a belief that informs a policy. There is a way of thinking that tells me how to act. The belief is this: there is no safe dose of radiation since stochastic effects have no thresholds. That is a belief. That is an understanding of the reality of the situation. All right, and we know that to be true because we've tested these things and we have the data. So that belief tells you what? It tells you how to act. It informs a policy, a fundamental principle. And so there's a very important fundamental principle that all radiologists, medical physicists, and doctors, they know about, and they are obligated to follow it. And it's called ALARA. And ALARA is a true acronym, unlike KERMA, but ALARA is a true acronym that represents the concept of reducing exposure to ionizing radiation. And ALARA stands for as low as reasonably achievable. All right, ALARA, it's important to know. It's just a key concept. You have to know ALARA, as low as reasonably achievable. It is an operating assumption, and every action that you take is predicated on the idea of ALARA, right? No dose is safe. And if no dose is safe, then you have to consider every time you give a dose to a patient, which you will be doing as a doctor or radiologist or medical physicist. Are you not putting them at risk? Yes, you are. Every single time. So you are compelled to keep that dose as low as you reasonably can do it and still do what you need to do. So it's an operating principle that is informed by a belief that because stochastic effects are the result of radiation, there is no safe dose of radiation. All right, so, and let's just take a look at some examples, because it's not like you fill out a chart for ALARA every time. It just teaches you how to act. All right, so ALARA, as low as reasonably achievable, is what that stands for. So these are the things that you're asking yourself. Could you produce a better PET or SPECT image if you injected the patient with a higher concentration of radionuclides? Yes, absolutely you could. We are taking images from outside the body and we're taking pictures of where the radioactive particles are congregating in the body. Would your image be, could it take less time? And would it be better contrast if you injected them with a massive amount of radionuclides? Yes, it would. Are you allowed to? No, because you are delivering dose to the patient, and all of that dose is detrimental. You are obligated to use the smallest amount that gives you the image that you need, not the best image, the first image that accomplishes what you want it to do, even though it's not perfect. ALARA tells you you have to use that much. Could you increase the contrast in an X-ray radiograph or a CT by doubling the exposure time? Just leave the patient in for twice as long. The answer is yes, absolutely. Your contrast will be better. All the tissues will stand out better from each other because the signal to noise will be much better. The signal will be better, the noise will go down because it's that quantum model that occurs. Are you allowed to do that? No, you're not, because it's a non-zero dose delivered by X-ray radiographs and CT. And just because it's easier for you to read the radiograph, you are not allowed by the principle of ALARA to expose the patient to greater dose than he or she needs to make that image. So say you are a coronary surgeon, heart doctor. A patient has a severe coronary blockage. You've got to use a fluoroscope. And we saw in a previous graph that a fluoroscope delivers a whopping dose to a patient, but you need it because you have to see if a stent is opening that coronary artery. And that's a lot of radiation. It's not safe. Are you allowed to actually use a fluoroscope in real time to determine where that stent goes? Yeah, you are, right? Because you have to make a decision. If you don't put in that stent, the blocked artery will kill the patient. All right, so can you do it with less? No. You will use the amount of radiation you need to determine where that stent is, and you will do it as many times as you have to convince yourself the stent is in place, and that is allowed because you have to, because the risk of not putting in that stent is death to the person. All right, so it is a reasonable thing to deliver that radiation as low as reasonably achievable, not as low as possibly achievable. What's reasonable? You have to be reasonable to save that patient's life. A patient has a thyroid tumor. Are you allowed to treat that tumor with 45 grays, I think this should say, of X-ray radiation? Yeah, sure. This is a lot of radiation. Is that not very dangerous for the patient? Yeah, you are. But we deliver radiation to treat cancers. It exposes them to non-zero risk, but if you did not treat them, that cancer could kill them. So it's a trade-off. You don't treat them with 90, you treat them with the minimal amount that you think has a reasonable best chance of curing the patient. Are you allowed to image the patient 25 times to monitor the progress of the tumor? Yeah, you can do that too. Does that dose from 25 X-rays or CTs, does that start to build up? Yes, it does. Yes, it does. Is it a non-zero dose? For sure. But you are allowed to do it because you need to be tracking, is that tumor responding to the radiation you're giving? That's a very reasonable thing to want to do. So ALARA does not mean zero dose. It does not. It just says what is reasonable and what's the minimal amount that will allow you to do what you want to do. Does it matter if the patient is 11 or 65? It actually does. It really does. Because many of these doses that you deliver, say from 25 CTs, they could cause cancers 20 or 30 years down the road. So the odds of a 65-year-old living to present with a secondary tumor, we call it, 30 years later is very, very, very small. So it is common that these patients can be treated more aggressively with radiation because honestly, they will not live to see the long-term effects. An 11-year-old has a long and healthy life in front of her, presumably, and so you're going to treat differently because you realize down the road they could get sick with these secondary cancers from the radiation that you're using. So you will treat them differently. So what is reasonable for the 65-year-old may not be reasonable for the 11-year-old. So there is no equation for this type of ethical medicine. It is just a guiding principle, and it requires a current understanding of what is the optimal amounts. So keeping up to date on the research, keeping up to date with the literature is going to be really, really important for these types of occupations. So it turns out let's just go back to this slide, that the risk can be calculated in some way. So this risk defines what we call a detriment. So the detriment to a person, so here's a table, 64, contribution of some organs to a whole body radiation, detriment. What is detriment? Detriment, in parentheses, is an idea that's a combination of probability of harm, severity of harm, and the time of onset. It's a little bit hand-wavy, a little bit nebulous, but it all has to be rolled into one, right? We've seen that. So if the probability is high, but you know that that probability is only going to occur in 80 years, that's a small detriment, right? It's not the same as the probability is high and you're going to get it tomorrow. Do you get that? So this idea of detriment rolls all these things together. And probability and when it occurs, and then how bad is it, right? Because the probability, oh man, 90% that's going to happen, and it's going to happen tomorrow, and the thing that happens is like a hangnail, that's a small detriment. So yeah, it's almost guaranteed to happen, and it's going to happen tomorrow, but it's like a hangnail. Who cares? So small detriment. So detriment has those three things folded into it. On the other hand, if it's 90% sure it's going to happen, and it happens tomorrow, and the thing that it is death, that's a very high detriment, right? So it folds in all these things. It's an attempt to put a number on that, right? So it kind of combines, and the people do study this, right? They look at outcomes, and these are what the actuaries can do, right? They can calculate, lost earning potential and how many days or months or weeks of your life do you lose. They try to give it a number to make it statistical. Insurance companies count on these things. They really do. So it's a combination of probability of harm, severity of harm, time of onset. And what it comes up with is this idea that we can put numbers on the amount of radiation you get, a cancer probability or severe genetic probability per sievert. How risky is it per sievert of radiation? So you remember the gray, absorbed dose, and then the gray times the RBE gives you the equivalent dose in sieverts. So that's really what we're talking about. What is your probability of getting cancer per sievert? That's what people really want to know. What's the probability of having a serious, this would be a heritable defect, per sievert? And then can we correct that numbers if you say, yeah, there's a probability of getting cancer, but we'll lower it a bit because we'll take the non-fatal cancers, which we can completely cure into effect. They do that too, okay? And when you do that, we come up with a risk per sievert, and it comes out to be this. So I'm going to jump to the end. I'll come back and I'll explain these things in red here in a second. But we come up with 500 times 10 to the minus 4 per sievert. So 500 times 10 to the minus 4 per sievert times the number of sievert tells you the cancer probability. So I did a quick example here. So remember we said, what is your allowed annual exposure? It's 50 millisievert. That's the kind of industrial limit. If you worked that at a power plant, you could get 50 millisievert per year before triggering any kind of, nothing. That's allowed by law and everything. So you just take 500 times 10 to the minus 4 times 50 millisievert, which is 0.050 sieverts. Do the calculation. That's 0.0025 multiplied by 100 to get 0.25%. So an exposure of your whole body, like walking through the power plant, of 50 millisieverts gives you a 0.25% chance more of getting cancer. It doesn't mean your chance of getting cancer is 0.25% because you might get it even if you didn't work at the power plant. We'll talk about that at the end of the lecture. All right, so that's how you use that defect. Does that make sense? If that doesn't make sense, stop now, go back, think about it, do this calculation, make sure it makes some sense to you. Okay. The next thing is then, this is if your whole body got irradiated walking through the power plant. What if you're just getting an X-ray or a CT and they're just irradiating one part of your body? Could you not take more radiation? And in fact, you could. All right. So this gives rise to the idea of the tissue weighting factor, WT. All right. Not all organs and tissues are equally sensitive to radiation. Right? So certainly your risk depends on what part of your body gets irradiated. I mean, I could, even without knowing the number, you could probably ask that. I said, hey, I have this X-ray gun here, and it's going to deliver 500 millisieverts. And where do you want me to shoot it? You want me to put it up against your ear and irradiate your brain? Or would you rather I just put it on your hand and irradiate your hand? Intuitively, you would go like my hand, right? You know that. You don't know why, but you know your hand's less sensitive. There's sensitive stuff up here, right? They're not at the same risk, and that is true. So when we do tissue calculations, we have this thing called the tissue weighting factor, WT, all right? WT 0.04, 0.05, 0.14, 0.18, et cetera, and that's going to contribute to the risk. I'll come back to this in just a second once we know what to do with WT. But this makes sense, right? And I'll talk about the size of these numbers in just a bit. So we will come back to WT. All right. So that idea of WT is going to feed into yet another dose. And again, why are these so similar? I don't know. Is it confusing? A little bit, yes. Do students get confused on this every year on the exam? Yeah, they do. Again, another little warning sign. Are you going to be the person who gets confused? Well, you and 50% of my class every other year will be confused, but maybe it doesn't have to be you. All right, so just think about it, get it straight. We have seen in previous units the idea of a new type of dose that we called equivalent dose. The equivalent dose had symbol H. It is measured in sieverts, and we saw that equivalent dose was the dose in gray times this W sub R, which was the radiation weighting factor, or also by the RBE. Like Kane would have just said it's the RBE, but really in the medical physics books, it would be W sub R, the weighting sub radiation. Radiation weighting factor means it's what type of radiation was it. Remember, that was the whole point of equivalent dose. Radiation weighting factor, X-rays, alphas, neutrons, etc. to get some equivalent dose in sieverts. All right? So that should be clear in your head. Now I'm going to add in another type of dose. So this is the effective dose. And I think why students get confused by it is just both words start with E. I would wish there's a more complicated reason why people get confused, but there's not. They're two E words. I can't keep them straight. Even I can't keep them straight sometimes. So I'm telling you, this is tricky. This is a trap. Make sure you don't fall into it. All you have to do is remember it for the exams and stuff, and then you'll be good. The effective dose is the sum of all the equivalent doses over all the tissues, taking the sensitivity of the tissue into account. So to get an effective dose, you just take that equivalent dose, which is H in sieverts, and you multiply it by the tissue weighting factor, that WT from that previous graph. And then if you were getting like a chest x-ray, it would be how much equivalent dose does your lungs get times the tissue weighting factor of the lungs, plus, that's why there's a summation sign there, plus how much equivalent dose does your heart get times the tissue weighting factor of your heart, plus the equivalent dose that your thyroid gets times the tissue weighting factor of the thyroid, and you sum all those up to get an effective dose. And that's a word, effective, that's where it comes from. I know it's hard to keep straight, but it's the best word for it, because if your heart got 1 sievert and your lungs got 3 sieverts and your pituitary or thyroid got 0.1 sievert, you add all that up, and once you sum them all up, it's as if your body effectively got blank, effective dose. It's as if you effectively got a whole body dose of blah. So that's what effective means. Not like, is it effective at damaging you? It's effectively as if your whole body got the same thing, meaning you're at the same risk. Okay, so equivalent dose and effective dose, very important to keep separate. If that doesn't make any sense, write it down. Ask me a question about it later, but these are very common dose ideas. So let's talk about these numbers again. So here is that table that I was showing you before with these W sub T's, these tissue weighting factors. The tissue weighting factors are going to give you the effective dose that you're getting. This was from 1991. This is the table from Hobby. I have another table from 1987 from a different book showing that they've changed a lot, but it's got a few more organs in here. So bladder, breast, stomach, gonads, breast, red bone marrow, lung, thyroid, bone surfaces, and everything else in your body. All right, and how to interpret these things. So let me tell you, help you interpret these guys. The higher the WT, the more sensitive that tissue is. All right. So I'll show you another slide on that in just a second. But just remember, the higher that is, the more sensitive the tissue is. The smaller it is, the more dose that you can take. So I like this chart. Let's just bring it back up so you can see it a little bit, because this was 16.4 showing what these guys are. So clearly on this chart, what's the most sensitive? Your gonads. These are your reproductive organs. You know that, right? Both male and female, the reproductive organs are very sensitive because you're producing lots of cells all the time, and they're reproducing, and they're very fragile, these stem cells. And if they get damaged by radiation, they pass on their effects very easily. And the stomach is very sensitive because it has a high amount of turnover, the epithelial layer inside. Let's see, the red bone marrow, very sensitive because it's producing lots of red blood cells all the time. A little bit of damage creates a big effect. So let's take a look at this. What are your major contributions to the effective dose from a typical CT head scan? So this was the example I was giving you before. So a CT head scan delivers 36 millisieverts to the brain, 3 millisieverts to your bone marrow, 5.5 millisieverts to the thyroid, and 14 millisieverts to the surfaces of your bone, your skull. Multiply each of these effective equivalent doses times the tissue weighting factor. That gives you WTHD. Sum all those up, and its effective dose of 1.8 millisievert. It means that a typical head CT, which delivers 36 millisieverts to the brain, 3 to the bone marrow, 5.5 millisieverts to the thyroid, and 14 millisieverts to the bone surface, that is effectively as if your whole body got 1.8 millisieverts. It's the same risk overall if you're just calculating how risky is that procedure. And then, of course, if you know what 1.8 millisievert is, then you can multiply that times that 500 times 10 to the minus 4 probability of getting cancer from a whole body dose. All right. So the smaller the CT, the WT value is, the more radiation that tissue can take. The higher the WT, the more sensitive that tissue is, right? And if you just think about it, that makes sense. So this number is the bone surface is very small. You got 14 millisieverts, but you multiply it by a small number. Yeah, it's as if your whole body got 0.14 millisieverts. That's not much at all. So when this number is big, you're multiplying whatever dose it got by a bigger number, which means like effectively you got a much bigger dose. All right, that's why a big number means dangerous, because it's effectively like your whole body got that dose. So you want small numbers on these tissue weighting factors. All right, so you can always think about the whole body dose limit of 50 millisievert. So what it means is if your whole body is allowed to get 50 millisievert, something with the tissue weighting factor around 0.1 can actually get 50 divided by 0.1, which would be 500 millisieverts before you get to that same dose. And the smaller that number is, then the higher radiation it can get before it's effectively like the whole body dose of 50. So this is a little confusing, but I think you can make it make some sense to yourself, because the smaller that number is, that's the thing that is multiplied by the dose. It keeps this number small, which means your total effective dose is also low. And that's what you want. Okay, so small is good, high is bad. It means it's very, very dangerous. So the bone marrow, the gonads, things like that are pretty at risk. Okay, so hopefully that makes sense. Again, if it doesn't, write it down and we can talk about it later. Okay, so now I want to do something a little bit different. I've got a question here, and this is something that you and I would be doing together in class. So what I want you to do right now is go get a blank piece of paper, a pencil, and a calculator. And because we would be doing this together in class, I want to try it and do it together with you right now online. But I do want you, I'm not going to do the calculations. I'm going to show you my steps of the calculations, but I actually want you doing it. So if I ask you to do this on an exam, you will be able to do it. And since there's not a homework on this, I need you to practice this problem. So pause it now. Go get your eraser, pencil, pen, paper, and a calculator, whatever you need to do a mathematical problem together. And press pause, and then when you're ready to go, just unpause me and we'll get going with it. So go ahead and press pause now. Okay, so you're back. So this is really important idea. This is problem 34 from Hobby if you want to do any of the Hobby problems, because that's where this is coming from. So Hobby's just saying this. Suppose that the probability P per year of some event which is that event could be death, mutations, cancer, whatever. For most of cancers, it consists of a spontaneous component, which we call S, and a component proportional to the dose of something else called D. So that probability is a spontaneous component S plus A times D. All right, so S is just the spontaneous risk, D is the dose, and A is how sensitive to dose that thing is. So it's a spontaneous component and a component caused by dose, which of course is true, right? And this is the problem with risk, and this is why I really want to go through this problem with you, because people in the public don't understand risk. If you don't get any radioactive dose from medical treatments, is your risk of getting cancer zero? Of course not. People get cancers all the time. And that just happens spontaneously. So if one extra person gets a cancer because they live out in Lakeshore or something, oh, Lakeshore's got a radiation problem. How do you know? Is one extra person significant? You don't know that. Can you calculate it? Yes, you can. But you have to do the calculation, and that's what we're going to do together. All right? So we're going to try to let's just read the problem. Investigations of women given mammograms showed that if P is the probability of acquiring breast cancer spontaneously 1.9 times 10 to the minus 3, and due to radiation 4 times 10 to the minus 4 per gray, how many women had to be studied to distinguish between A equals 0, which means there's no risk of radiation from a mammogram, and the value above, which is what it actually is, 4 times 10 to the minus 4 per gray, if D was 2 gray? And what about if D was 10 to the minus 2 gray? So what we're saying is this. If you want to know if mammograms cause cancer, how are you going to know? This is what we're going to do together. What you have to do is look at a group of women who none of them have mammograms, and then how many of those get cancer? Okay? Then look at a group the same size that do get mammograms, and how many more of them need to get cancer before you know for sure the mammograms cause cancer, right? And then what is the risk per dose that they got? You can't just guess and you can't just count. You have to do the calculation. So let's go ahead and do that. So the first thing you should do, we're going to try to solve for this equation. So P equals S plus AD. That's the equation. So go ahead and write that down. And every time you're given a problem like that, you should probably just try to start and write down what you know. So there's P equals S plus AD. S is the spontaneous rate, so I wrote that down, 1.91 times 10 to the minus 3 it was. A equals 4 times 10 to the minus 4 per gray. And let's just do the first part. I'll leave the second part to you. Dose of the mammograms is 2 gray. So we know S, A, and D. How many women had to be studied to prove that? So what I'm going to do is I am going to read you what I want you to do. I'm going to give you a second to think about it. You can pause, and then I'll come back and show you what I did. Okay? So my first question to you is, if no women get mammograms, what is the probability of getting cancer? If no women get mammograms, P equals what? Pause now and write that down. It's step 1. Okay? What I wrote for that is, if you get no mammograms, the dose is 0, so the probability equals S. All right? That's it. Probability equals S. That's pretty easy. Okay, so that's step 1, so put a 1 next to it. Now step 2, write a 2 right next to it. If you then examine, test N women, so capital N are the number of women you test, that's the group size, capital N, how many of those are going to get cancer? If the probability you just calculated in step 1 is P, and you test N women, how many of them get cancer? When you're ready, unpause and look at what I've got here. This is what I came up with. The number who get cancer out of a group of N has to be NP, or which is NS, right? The number who get cancer, M, is the number you test, N, times the probability, P. That makes sense. And since P was just equal to S from step 1, then the number of women who get cancer just should be N times S. That was step 2. Does that make sense? If that doesn't make sense, think about it. I think you will. That's the easy part. We're not even at the hard part yet. Now, step 3, circle. What's your uncertainty in that number? Are you sure? So say you studied 10,000 women, and you calculate the probability, and you multiply it times that, and whatever number you get. So 20 women got cancer. Is there any uncertainty on that number at all? Means if you measure another 10,000 women, is it always going to be 20 every single time? It can't be, right? So you measure 10,000 women here, you might measure 20. You measure 10,000 women over here, it might be 15. You measure 10,000 women over there, it could be 30. So it's 20 plus or minus what? How do we account for that? Do you remember? Well, that's a very, very simple number. That's another counting statistics question. So you should remember that. Whoop, let's move it over here. Sorry. So the point of that is that there. The standard deviation sigma is equal to the square root of m, where m was the number who got it. So it's the square root of n times s. Right? That makes sense. We did that before with counting statistics. Whatever you count m, it's the square root of m. That's the uncertainty on it. This is standard deviation. Okay, so that seemed to work pretty good. Now, so we have steps 1, 2, and 3. So we have determined that with no mammograms, P equals S, step 1. The number who get cancer out of a group of capital N was little m, which was capital N times P, or N times S, step 2. Step 3 was, what's the uncertainty on that? Square root of N times S. Great. That was all the without mammograms part, steps 1, 2, and 3. Now, we need to do the with mammograms part. So what is the probability of getting cancers if you have a mammogram? So I don't want to call this P again because we just used P. So I'm going to use P prime. All right, so that's the equation that we were given at the beginning. There it is up right underneath my finger. P prime is equal to S plus AD. All right, we were given that. No problem. But now we want to know P prime. I just don't want to call it P because I don't want to get confused. All right, so that's the probability. So now my question is, if you test the same number of women, capital N, how many cancers are going to get there? So step 4 was, what's the probability of mammograms? P prime equals S plus AD. Step number 5, circle. Of those women, how many get cancers? All right, and I'm going to call that little m prime. So the number of women who got cancers in step 2 was little m. And I'm going to call the number of women who get cancers now m prime. All right, and it's going to look something like this. This is what I think. All right, m prime, it's the same number n. That's the key. Capital N now times P prime. But I know what P prime is. It's S plus AD. So just multiply that all out. So the number of women m prime is equal to n times S, which was little m, plus NAD. All right, and that makes sense. What's the step 6 is, what's the uncertainty on that? Seems pretty straightforward. The uncertainty on that I'm going to call sigma prime. And so sigma prime should be the square root of m prime, where m prime is what we just calculated in step 5. So the square root of m prime is the square root of the quantity n times S plus AD. All right. And when you think about it, really, that's what we were trying to get at. All right. So step 7 now is you've actually done the math, but you didn't realize it. So let's look at step 7. What you're trying to figure out is, when is m, the rate of women, the number of women who get cancers without mammograms, plus its uncertainty, for how many women is that number less than or equal to m prime minus sigma prime, which is the number of women who get cancer with mammograms less its uncertainty. Well, I guess what I'm saying is the number of women who get cancers without mammograms and their uncertainty is a bar like this. If the number of women who get cancers with mammograms and their uncertainty is like this, can you tell if those are different? No, you can't. So M is here. This is M plus sigma. That's M minus sigma. This is M prime. It's only when the number M prime is bigger, but M prime minus sigma prime is bigger than M plus sigma that these two error bars are not overlapped anymore. At that point, you say, yep, they're distinguishable. This one for sure is real. That's a real effect because it's outside of its error bar, right? That has to be true. So what we're trying to get at is a graph like this. So let's just look at it this way. So here is the number of cancers. This is M, which was equal to N times P as a function of dose. These women are not getting any mammograms at all. So the number you calculated, M, even though we don't know N, that's fine. It's some number. N is something, which means M is something. It's just a flat line. M equals N times P plus sigma or minus sigma. This is the error bar on M. That should make sense to you. So that came from steps 1, 2, and 3. From steps 4, 5, and 6, we came up with this. We said, okay, but now the number of women who get mammograms who get cancer is M prime. M prime, we said, in step 5, was M plus N times A times D. And it had an uncertainty sigma prime. But M plus N AD depends on dose, which is why it's going up as a function of dose. Now, of course, when dose equals 0, M prime equals M, which is right here. That's why they overlap. But the dose goes up, and it just increases linearly with dose. And what I was asking you is, it is statistically significant now, not here, right? It's not as soon as M prime is bigger than M because there's uncertainty on it. It has to be at this point here that M prime minus its uncertainty is bigger than M plus its uncertainty. They're separated. At this point right here, the two error bars become separated. So at every dose higher than this, you're in a regime now where these numbers are statistically true. Okay? Does that make some kind of sense? So I want to know, my question is when is M plus sigma less than M prime minus sigma? All right, that's what I'm really getting at. So I did that by this way, and I think I'll post this online for you afterwards. You can look at it as well, but go ahead and look at my work. So I'm on step 8 right here, where M plus sigma is less than M plus NAD minus sigma prime. That's the equation, and I know all those things before. So I just move all the sigma plus sigma prime to the other side of the inequality. I set it equal because I want to know what value are they actually equal. That's the value. That's the dose, below which they're not separable, above which they are separable. Then I solve for N, sigma plus sigma prime, all over AD. This is algebra. You guys can all do this. I know what sigma is, N equals square root of NS. I know what sigma prime is, square root of N plus square root of S plus AD. It's all over AD. I solve for square root of N. Right, so I just factor out a square root of everything, divide it over. It's just algebra. You got to look at it. And I eventually wind up with the square root of N is equal to the square root of S plus square root of S plus AD all over AD. And I know those numbers. They gave those problems in the problem. So S I plug in, A times D. Remember, I'm using the problem where D is 2 gray. I know what AD is. I divide by that. I find that the square root of N is 120. Square both sides to get N equals 14,400 cancers. Right? So in a group of 14,400 women, that is when the number of cancers becomes noticeably, statistically, significantly different for the women who get mammograms. We haven't even calculated the number of cancers yet, but let's do that now. How many excess cancers is that? Well, we now know N. Now you can just go back and do all these other things, right? So how many excess cancers is that? The number of women who get cancer spontaneously is 14,400 times that spontaneous rate, which you have written down, and I get 22.5 plus or minus 5.2. The number of women who get cancers from the radiation is N plus NAD. Calculate that out. So NAD are the number of excess cancers, right? Because NS you've already calculated. M prime is NS plus NAD. So it turns out that NAD in this case turns out to be 11.5 extra cancers. So if you test 14,400 women, it says that you were going to find that, 27, it's 27, I apologize if I said 22 before, it's 27.5. If you randomly pick 14,400 women, 27.5 of them are going to have cancers. All right. If you pick 14,400 women and all of them have had mammograms and have gotten 2 gray, then you're going to find 27.5 plus 11.5, which is what, 39 of them will have cancers. So that's 11.5 more, and that is a statistically significant amount, all right, because it's greater than the square root of m. It's greater than m plus the square root of m. Okay, so I need you to be able to do a calculation like that. So you've seen me go through it together. There's no homework on this unit. I'm not assigning it, but I need you to know how to do that. So go through this problem again. It's on this slide right here. Here's the whole question all written out. Go back, write it all down. Make sure that you can do that calculation. Okay, and just for fun, we have a multiple choice question. So let's finish up our lecture with a multiple choice question. Why not? So if you're given this question, which is the correct explanation for how deterministic D versus stochastic S depends on absorbed dose? This is like a quiz to remember if you talked about what we talked about earlier today. Which of these 5 things is true? As always, pause it now, take a minute, write down your answer, and then unpause when you're ready to see the answer. So pause now. Okay, you're back. So one of these 5 has to be true. The other 4 are not true. Did you remember and keep straight what deterministic and stochastic meant? It's going to be important that you remember those things for sure. Yeah, it was number 4, right? Things that are deterministic, the probability has a threshold, severity has a threshold. They're both as a dose below which you're okay. For stochastic, probability has no threshold, severity has no threshold. That's the definition of a deterministic and stochastic probability. Okay? So I hope you remembered that. That's kind of important to know. Here's another trickier question. So you're trying to prove, so say you have suspicions or you have some uncle who thinks, oh man, these crazy radioactive cups that they're selling down at the dollar store cause cancer in people. You're like, whoa, that's hard to believe, but okay, I'm a physicist, I can figure that out. So I take a large group of people who have never encountered those cups. So I'm going to prove it. You got to prove to your uncle whether these cups cause cancer or not. So I get a large group of people and you ask each one of them, have you ever had these cups from a dollar store? They say no. It's a large group. How many? 10,000? A million? I don't know. But it's a number and you know it. And you find that many people have never bought a cup and you find 100 of them have cancers clearly unrelated to the cup because they've never had the cup. 100 cancers in a group of N. You then take the same size group, which is large, but all these people have used cups, that cup from the dollar store. How many cancers do you need to find? Now remember, you found 100 in the group who had never had a cup. How many cancers do you need to find in this new group of people, all of whom drank cups, to prove to me and to your uncle with a 95% confidence that those cups in fact cause cancer? How many cancers do you think you need to find? So go ahead and pause it now, and when you're ready, we'll come back and talk about the answer. So pause now. Okay, you're back. You had some answers here. Hopefully you realize for sure it's not 10, right? You do not expect to find less cancers. 100 people in the group who never encountered the cup had cancer. Certainly it has to be bigger than 100. Is 1 enough, right? If 100 people who never had the cup, would just 1 more do it? Seems unlikely because you know there's some variation in that 100. So how do you come up with that? Well, the square root of 100 is 10. So in the group that you tested without ever having encountered a cup, it's 100 plus or minus 10 is the uncertainty on that. And to have an excess to be more than 95% confident requires an excess of 2 times 10, which we call a 2 sigma deviation. The see Kane, page 321, for a discussion of 95% confidence intervals. If it was 3 sigma, 131 is not a bad answer. If you said that, I would accept that as well. That makes you 99.7% confident. Yep, those cups cause cancer. But a lot of times in medicine, they say 95% is pretty certain. I feel pretty good about that, and that's a 2 sigma determination. So sigma was the square root was 10. 2 times sigma is 20. So when you measured 100 in the control group, you could reasonably next time expect to find 120 or 80, anything in between. But 121, you're 95% likely that actually is in excess of 120, and that's actually a real effect. So statistics, risk, detriment, doing calculations, calculating probability, thinking about sizes of people. This is why it's so hard to know how radiation is. We saw for that, how many women did you have to study to see if mammograms increase rates of cancer? It was 14,000 women, and that was when they get 2 gray. They don't get 2 gray. They get a factor of like 100 smaller, and the number doesn't scale by just 100. It could be bigger than that. So you need lots of people to prove even small increases of cancer, and most people just don't believe that. If they know 1 or 2 people who get sick, oh, there must be a cancer cluster. It doesn't work that way. You've really got to do the numbers. You statistically expect some places to have more or less. I'm not saying it's not real. It's just saying you actually have to do the calculations to determine, is this thing really statistically more dangerous than this place where they have never encountered that risk? Again, most people don't understand that, but you're a physicist now. It's your responsibility to understand these things, to be able to respond rationally and reasonably, to do some calculations, to let people know whether these are things to be concerned about or not. That's your job. Okay, that's the end of the lecture. Hope you enjoyed and got something out of this. We've got one more to go, so I will see you next time. Take it easy.